This is actually pretty exciting. We had on Tuesday we had about 50 people register, and we had somewhere around 35 to 40 actually attend the webinar. Um, I'm especially excited for several reasons. Number one, I like the topic. It appeals to many people, in addition to chronic floater sufferers. So there's a lot of people that might be interested in joining today. I think this is a rather unique experience where a doctor and um, interested viewers can interact directly in real time. So for those of you that chimed in early, I'd like to just basically thank you for your participation because I think this is a very unique event, and hopefully we'll be able to do more of these. I had initially I was hoping we could do this as a Google Hangout, but with my limited experience, it seems as though you're capped or limited to only 9 participants. Chase, thanks for saying thank you. Dan Dooney, I can't read the whole question. Yes, this presentation is going to be recorded. Because of the length, I'm not so sure how long it will take to edit it. When we did this on Tuesday, although the PowerPoint presentation is 15 to 20 minutes at most, the entire webinar lasted about 80 to 90 minutes. And I'm not so sure I want to upload that as one large file, and it may require some editing. But I am planning on doing that. I definitely am going to send everyone who attends today a copy of the slides. I'm also looking into the possibility of having everything transcribed to text and either publishing. Hey, Vernon, how are you? Um, I'm looking into having everything transcribed either to PDF or put it into some series on SlideShare and embed it on my website. It's 3:02 p.m. Eastern Standard Time, United States. I'm Randy Wong. We're going to get started in just a few minutes. This is my second clinical webinar. Our first was done on Tuesday with the same subject. You didn't miss anything. It's about floaters, evaluation, and treatment. Um, I'm a retina specialist. I'm an ophthalmologist with specialty training as a vitreoretinal surgeon or a retina specialist. And one of our domains, or something that we deal frequently with, is floaters. To get my specialization, I had to complete medical school. Then I had to do an internship and then a residency to become a general ophthalmologist. And after that, I performed a fellowship, which is an extra year of training that allows me to deal only with the retina and the vitreous. And floaters are the domain of a retina specialist because floaters, by definition, are only in the vitreous. It's 3:03. I think, why don't we get started? We're all here today because we have a common interest in floaters. The webinar today is going to be about the evaluation and treatment of floaters. Uh, for those of you, I think most everyone is here because you're familiar with my website, retinaeyedoctor.com. I started retinaeyedoctor.com about 4 years ago as a challenge for my wife, Amy, who many of you have communicated with. It has been a great source of information for existing patients and has become, as many of you know, a great source of information for you. I'm a practicing and licensed I'm a practicing ophthalmologist in Fairfax, Virginia. I hold a medical license for the state of Virginia only. I must say that although we are all communicating today, this is not establishing a doctor-patient relationship, and I flatly have to deny that I am your doctor, and any questions or problems that you have resulting from today, you should consult your own doctor. Having said that, I do have several patients that I've actually operated on joining us today, so I am still those specific people's doctor. Uh, as I had mentioned earlier, I am an ophthalmologist with specialty training in as a retina specialist, and retina specialists deal with eye problems such as diabetic retinopathy, macular degeneration, detached retinas, and floaters. Over the last year, the website gained a lot of traffic whenever we would talk about floaters, especially chronic floaters. And I thought this would be a unique idea to reach out to all those people interested in a different way and communicate live. So let's get started. I have a short presentation. It will last about 15 to 20 minutes. After I finish the presentation, I'm going to open it up to questions. And the questions I'm going to ask you to just type in the chat area or where it says questions. Uh, the webinar that we did several days ago, the Q&A session lasted about 40 to 45 minutes, and I was able to move through the questions and answer almost everybody's by simply reading them. So let's get started. If you have questions as I'm talking, I should be able to multitask and see your question. All right, what we're going to do today is define what floaters are. We're going to discuss several of the causes, talk about why persistent or chronic floaters can decrease your vision, and talk about the few treatment options, and talk about the problems or risks of FOV, which is known as floater-only vitrectomy, which is also in my world just is known as a standard vitrectomy. And then we'll have a Q&A session. What are floaters? In my opinion, floaters are anything bothering your vision that moves to and fro with eye movement. And what I mean by to and fro is if you were to look left or right, there's a lag time, but whatever you're seeing moves left and right as well. Because floaters are suspended in the vitreous. It behaves as though the floaters are suspended in a gel. The same would happen if you look up or down. The floaters would quickly regain the same position in your vision. There is no specific morphology. That means there's no specific color to floaters that can bother you. There's no specific size to the floaters. They can be big or small, and there's no specific shape. So it's really anything, any color, any size, any shape of something in your vision that moves to and fro with eye movement. And by definition, that it can only be located in the vitreous. The vitreous is the gel-like substance that fills the eye, and in this schematic, it is all this cotton or wispy-looking material right in the center of the eye. The gel is not actually filled with water. It is filled with a gelatinous substance called the vitreous, which is mostly water. It's about 94% water, but it does have some substance just as jellyfish has substance. The vitreous occupies pretty much all of the inside of the eye behind the lens. And again, it's mostly water. Within that space, debris can accumulate, blood can accumulate, or changes in the clarity of the proteins itself can cause floaters. The most common cause of floaters is something called a PVD, or a posterior vitreous detachment. A PVD is a naturally occurring event. That means it happens to everybody. The older we get, the more frequent the occurrence. The vitreous, which is normally clear, can get cloudy, and that's that fancy term I use for opacification. There can be changes in the actual protein, which cause these spots to form in your vision. Optical properties of the vitreous are normally such that a patient or a person cannot see his or her own vitreous. But sometimes with aging, the optical properties of this protein make the vitreous less clear, so that there are portions of the vitreous that become cloudy and start to decrease the vision. Other causes of floaters can be such as inflammation. The clinical term for inflammation in the eye is called uveitis. A similar problem elsewhere in the body is like arthritis. I'm sure many of you either have or know people that have swelling of the knee joints or the fingers due to arthritis. And this is a specific type of inflammation of that joint. You can think of uveitis as inflammation or arthritis of the eye. And what happens here is that white cells or inflammatory cells can actually migrate into the center of the eye and start to build up, and these can cause floaters as well. A retinal tear can cause floaters for three reasons actually. Either there's a change in the clarity of the vitreous, cells from underneath the retina can be seen in the center of the eye, or bleeding can occur. Certain stages of diabetic retinopathy can cause bleeding in the eye, and the blood in the eye can be termed as floaters as well. Here are two pictures. On the left is proliferative diabetic retinopathy, and that's the specific stage of eye disease that diabetes causes, where abnormal blood vessels form on the surface of the retina, and they can spontaneously bleed into the vitreous, causing floaters. And here's just an enlargement of the abnormal blood vessels, and this haziness is just blood accumulating within the vitreous, and these are actually vitrectomy instruments to help remove the blood from the center part of the eye. So what we see on the right is actually a vitrectomy, and it's no different than the vitrectomy that would be performed, and I'll show you this later, during an FOV. Vitrectomy and FOV are absolutely synonymous. Here's a nice schematic of a posterior vitreous detachment, and this is the most common event where floaters developed. And the posterior or the vitreous can be seen to fill the entire part of the eye. And in the back or the posterior part of this gel-like sac, you can see this clear space here, how it's starting to pull away from the retina. The retina is the orange lining of the inside of the eye. So the vitreous is actually separating from the surface of the retina. And when this does that, it can cause floaters along this interface. And for some reason, there is often a change or increase in the density of opacities within the vitreous. My recommendation, and my large disclaimer, of course, is that anyone who experiences new floaters must get examined. The principal reason is we need to rule out a retinal tear, which is the most common problematic cause of floaters. We also need to rule out a vitreous hemorrhage from other retinal disease. In short, you need to ensure that there's no disease that can be treated to prevent permanent vision loss. New floaters should get checked out within 48 to 72 hours of onset. So what we're going to talk about now are floaters that persist, floaters that are not related to systemic disease, floaters that are not related to eye disease. And we're going to talk about floaters that simply just stay there. They're persistent and they don't go away. They're decreasing your vision. They can blur your vision. They can bother your vision just because of the copious or the number of floaters, or they can cause glare. Let's step back a little bit and talk about the most common cause of blurry vision, and that's cataracts. And in my estimation, they have basically the same symptoms as chronic floaters. Both cause progressive decrease in vision, both can cause glare. In both instances, you, the patient, are not able to see as well as you'd like. Treatment of floaters is, as you all are aware, somewhat controversial. Most people recommend observation. That's the fancy way of saying, let's do nothing. The problem is that you have the same complaints as patients with cataracts. And the inconsistency that I see is that The same doctor that would recommend cataract surgery for someone that is having decreased vision from um, cataracts, they'd recommend cataract surgery. But when it comes to floaters, how many of you have been discounted before, telling you that you're either crazy or you need to live with them or they'll go away, etc.? And the reason everyone is here today is because none of these things have come true. So now you're looking for options. What are your options to get rid of the floaters? There are only two that I'm aware of. One is laser, and this is with a YAG laser, and the other is a vitrectomy or an FOV. As I covered a second ago, if you decide to observe or do nothing, you may or may not adapt to the floaters. If you do adapt, great. Life goes on. You have these small floaters, they don't bother you. You're not too worried about them. But if you don't, you become frustrated. You have to consider the laser, or you must consider vitrectomy. The YAG laser has gained some popularity, at least on the internet. It's a very popular treatment option. Curiously, it's offered by very few specialists. I know of only 3 doctors in the United States that offer this as a treatment. I do know that the YAG laser cannot treat all floaters, especially floaters that are close to the retinal surface. And that's why I say they can only treat certain floaters. They can also only treat floaters that can be seen by the doctor. Also, just as curious as we don't know how risky these procedures are, because the doctors that perform this claim that this procedure is 100% safe. And I've been a doctor for about 21 years, and I'm not aware of any procedure yet which is 100% without complications. The last remark I'm going to make about the YAG laser is the 3 people that offer this are not retina specialists. Let's talk a minute about defining vitrectomy, otherwise known as FOV. Again, FOV is synonymous with vitrectomy. The procedure vitrectomy is no different for FOV, except that FOV just tells you why the vitrectomy is being performed. It removes most of the vitreous. Removing all of the vitreous is impossible, but the goal of surgery is to remove the central vitreous and basically clear the visual path to make it free of floaters. It does not require specific visualization by the doctor to be successful. And the reason is that the vitreous is a tissue which can be which is easily removed, so-called en bloc or in one piece, if you will. In my experience, it's been effective in almost all cases, and the risks are absolutely known. The risks are the most common risks or the most deadliest, the most grave risks are blindness from infection. The chance of blindness from vitrectomy is about 1 chance in 10,000 to 1 chance in 15,000, compared to cataract surgery, which is around 1 in 2,000 to 1 in 3,000. So, in terms of safety with respect to infection, vitrectomy is safer than cataract surgery. The chance of causing a retinal tear that leads to a retinal detachment is about 1% in both vitrectomy and cataract surgery. So when we talk about vitrectomy, we're actually talking about a very safe procedure, especially when compared to cataract surgery. And I choose cataract surgery because that's the most common surgery performed in the United States. There is a lot of misinformation out there about the dangers of vitrectomy, and that's a very dangerous procedure. I think that may have had some merit in the late 1970s or early 1980s when the procedure was actually introduced. But in the last 20 to 30 years, technology has made this, as you've seen, as safe or safer than the most common eye surgery performed, and that's cataract surgery. This is a nice picture of a vitrectomy. There will be 3 ports or 3 holes made into the side of the eye, and this is called the vitrector, and it has a small hole here which engages or sucks in the vitreous, and by a guillotine action, cuts every tiny little bite of the vitreous and then sucks it up this pipe and out to the machine. This is basically a flashlight or a light source, which allows me to see in the eye. And if you can see this little rubber tube here, this is pumping saline into the eye to keep the eye inflated. And this is a standard vitrectomy. There could be blood here, there could be a retinal detachment here, there could be something wrong with the retina, but this is the standard technique I would use to begin any retinal surgery. I got ahead of myself in the other slide. These are the major risks of vitrectomy or FOV. Blindness from infection is everyone's worry. And again, the chance of getting an infection that could blind you is less than cataract surgery. And the chances of losing vision to a retinal detachment is probably about the same as cataract surgery, although not necessarily blinding. Here again is the posterior vitreous detachment, and in this case, we will be focusing our attention on removing the floaters here. As I said, it's impossible to remove all of the vitreous, and what I would do surgically, my goal is to remove most of the central vitreous, and as we'll talk about, I'm sure, in the question and answer period, doing so without inducing a PVD. But don't start asking questions now. We'll get to that. So for those of you who've been reading a lot, FOV is basically a core vitrectomy. And as I've said several times ad nauseum, and I don't mean to repeat myself too many times, but there's nothing technically different between any other vitrectomy and an FOV. It's the same procedure. It's just the indication or reason for doing that procedure which is different. I do not believe that inducing a PVD is in anyone's best interest. That is, I do not think it's safe. I do not induce PVD during an FOV because I don't think there's any need to do so. I believe that the chance of causing a retinal tear is too high, and remember, a retinal tear can cause a retinal detachment. Keep in mind that every PVD does not cause floaters. I get a lot of questions about or concerns saying that if you do an FOV, you don't induce a PVD. What happens when a PVD occurs? Aren't the floaters going to come back? And the answer is that most people do not get vitrectomy. Most people do get a PVD. Most people don't even know they've had a PVD because they don't suffer or they don't see any floaters. Well, let's say you do have the operation. There is less vitreous. You've debulked the eye of vitreous. In my opinion, you're certainly going to delay the PVD, perhaps for 10, 20, 30 years. And for those 10 to 20, 30 years, you're going to be floater free. The FDA recently approved an injectable medicine called ochraplasmin. I don't know why this has gained so much energy or interest in the floater community because I'm not so sure this is going to help with floaters. If you've got floaters and you do not have a PVD, I think the ochraplasmin could in fact cause a PVD but make the floaters worse. Basically, the ochraplasmin, if it does anything, may just shift the location of the floaters elsewhere in the eye, making them better and perhaps making them worse. What I'm most concerned about is the risk of infection from the injection. We do eye injections, retina specialists, do eye injections commonly for lots of problems or lots of other retinal diseases. The risk of infection from the injections or the needles into the eye are actually higher than doing a vitrectomy. So I'm curious as to why one might consider a needle or an injection when actually the operation may be safer. And also, I'm not so sure, again, that oculoplasmin will do anything for the floaters. And that's why I say vitrectomy may be more definitive. There's some concerns about floaters that are in the premacular bursa, and the premacular bursa is that area of the vitreous right in front of the macula. And again, these floaters cannot be treated with the YAG laser because the YAG laser has to be focused too close to the retina, and the fear is that the laser will cause some damage, some direct damage to the retina itself. As I said earlier, this is not an issue at all with vitrectomy. It is now 3:25. That's actually the end of the lecture. I'm going to get myself a little bit organized. I'm going to tell you that this has been recorded